Welcome to the series of podcasts, Action on Health Inequalities, by Medical Care Driving Change. We'll be exploring health inequalities, why we need to be doing work to address health inequalities, and hopefully equipping colleagues with tools and tips on how to start to do this improvement work. For today's episode, I'm joined again by my co-hosts Aicha and Katie, and we'll be talking today about access. For those who can't remember, I'm Ruw. I'm geriatrician and Director of Health Equality and Inclusion at University Hospitals of Leicester. Aicha.
Hi, I'm Aicha. I'm a rheumatology consultant in Lewisham and Greenwich NHS Trust. I'm also a consultant in adolescent rheumatology at University College London Hospital and one of the content advisor in Medical Care Driving Change.
I'm Katie Malbon. I'm a general paediatrician at Imperial College Healthcare NHS Trust, and I have a special interest in adolescent medicine.
Welcome back. Thanks for joining us today. In previous podcasts, we've talked about why we're doing this work, why it matters, and we've talked a little bit about the training that we may or may not have experienced in starting to address some of the problems with health equity. But it would be really good today to start to talk about some of the practical ways that we see this impacting patient care, and also the ways in which we are starting to address some of that. So access. When we think about access, for me as a geriatrician, I think about patients coming to the services that we provide. I think when we talk to other colleagues, sometimes there's a conversation around not attending services and also not knowing which services are the best ones for patients. In your experience so far, what have you noticed around access and the way the wider determinants affect people's ability to access services? I'll go to Katie first.
Well, I guess a lot of my work is with adolescents, and of course we're offering appointments during school hours, and so it's no surprise that these get missed or are difficult for patients to attend. We should be thinking about having clinics out of hours, but this is quite difficult to do in a very sort of traditional system where we're used to doing clinics between 9 and 5. And it seems really just so difficult to disrupt that system. So I do an evening clinic in adolescent rheumatology once a month, but I'd love to be seeing all the patients sort of 11 and above in an evening or late afternoon clinic. And somehow we need to be able to do that more easily. And certainly in my trust that could be quite difficult.
So there's something in there around planned care, but how we are planning care around patients' needs rather than our systems. I think that's what I'm hearing.
Yeah.
And certainly if I reflect back my experience in geriatric medicine, we've noticed that patients are struggling to get to 9 o'clock in the morning appointments, particularly on Mondays. So adapting to their needs.
And actually even thinking about going into schools and doing clinics within schools, because already patients are missing school because of their condition. We shouldn't be adding to that by making them miss more school. And these are really formative years where they should be there.
So taking care to the place where patients are able to get access to the care.
Yeah.
And then Aicha, just building on that a little bit, have you any examples and done any work thinking about exploring with patients the barriers that they find to coming to planned care appointments?
Yeah, absolutely. And probably before we even think about coming to appointment, we may need to take a step back and think about the value that actually are trying to get from that hospital appointment. And if we think back about the actual what influence our health outcome in general, it goes back to the psychosocial environments, and there are certain barriers that actually stop and inhibit people from staying well and remaining well, and they become unwell, and then they get difficulty to access a system that help to fix some of those medical problems. So probably as a first step, before we think about how to access care, we may need to take a step back and think about the value that the patient is trying to get from that healthcare system, and whether hospital or hospital appointment is the right place to get that value for the patients. So what we've learned from working with young people on projects on health inequality is actually most of the questions sometimes are not related directly to health condition, even if they have a long-term condition, but is around different stressors that they go through from, particularly around educations and school, pressure from their peers that cause that stress, and therefore it does impact on their level of wellness. And over time, they feel that I'm always going to be unwell, in that illness paradigm, make them more passively just following whatever resources and fully relying on a system that is already struggling to provide those resources.
Yeah, and so I'm interested in that mindset perspective around what's the appointment for, what our understanding of what the appointment's for versus what the patient's understanding is of what the appointment's for. And so just as an example, one of the questions I ask my patients every time is, do you know why you're here? Just to check we're on the same page. And sometimes we're not on the same page, and then you have to figure out a way to bring those two things together. One of the questions that I'm not so good at asking, that I should be better at asking, is around the challenges that people find coming to the clinic that I do. Have you got any experience, either of you, of particular barriers that people face when they're coming to those appointments in a planned way?
Yeah, from my experience because we, in our projects, looking at the reason for clinic non-attendance, particularly among young people. So there are several barriers, some of them related to communication, actually not receiving the information about clinic appointments. Also, young people go through lots of transitions, socially, psychologically, and they find it hard to keep up with their appointments, and they need support with developing their organizational skills and keep up on the top of their appointments, medication, as well as educational requirements and academic aspirations. So all of that can have significant impact. But also there is an element of how we empower our patient to take that ownership of their health, because traditionally patients got used to a system that give them answers to their questions, and they are not empowered to identify what works and what doesn't work for them. So having a conversation where patients actually have a chance to reflect and build a new relationship with the problem they have, and think about what resources they may identify as you go through that process and that conversation, it will empower them to take ownership of their health and test ideas, their own ideas, rather than us suggesting ideas for them. Yesterday, I had consultations with the patient in my rheumatology clinic where she felt that her disease is making her very tired. She used to work 4 days a week, now she can do only 2 days a week. But actually, by asking her questions about what else is getting in the way from feeling well, it ended up like her home situation. She's a single mom, she has 2 teenagers, she's struggling to help them, with their educational achievements. One of them stopped going to school, and she's struggling with taking care of them as well as the house. She said, my house is in a mess, I don't have family, I don't have help, I'm struggling. So that's what's affecting her more than the disease, because because over time, each time she sees someone, a colleague, she was told, oh, your disease is not active, that's not the cause of your fatigue. But we didn't go a bit further to listen to what's going on around her and what else is happening around her and what resource could be around that, but she was not made aware of, that could help her to go through these particular challenges.
It's a really powerful example. And then I'm thinking then, Katie, around the pushback and the challenge back that we get around, is this really the role of healthcare? So you've identified as a doctor that it's not the disease that's causing the problem. So just thinking then about how can we start to bring this idea of actually those wider determinants are playing on the healthcare component, and how can we start to take some accountability of that in helping patients to come to us?
Well, one of the things, again, is working closely with schools, and so having, a wider view of what is going on in that young person's life. I mean, I think part of my practice is actually doing gynecology clinics, and I do that with an adult gynecologist. So the gynecologist is focusing on the medical problem, but I'm there as a paediatrician and looking at the wider aspects of their health and well-being. And that works incredibly well because we are tackling everything in one visit. It means that the patient doesn't have to go to a paediatrician and then go and see a gynecologist, or vice versa. So I think that's a great way to do it, and I certainly see that working in my practice. The challenge is time, and I'm trying to fit this into a traditional system where I'm expected really to see 9 patients in an afternoon, and that's quite challenging if you're going to cover those wider aspects of the person's well-being. So somehow we need to get that across to managers, that actually how it is efficient and actually much more economical, because you're covering so much more, and these patients are less likely to then attend the emergency department or go back to their GP. So you're preventing other appointments happening. But I think it's hard to see how to sort of convince the sort of management that they have to make these appointments longer.
So that's really interesting. There's 2 bits in there. I think you've mentioned the emergency pathway, which I think we'll come on to, and then thinking around how, as clinicians, we can have a role in identifying and working with our patients to identify the barriers to access, but then how do we turn that into a system or a process? So some of the work we've been doing in Leicester around contacting our most deprived patients before their appointments, and we know that when we do that, they're more likely to attend. And when we don't do that, or when we're not able to do that, the reasons why they're not attending are really insightful. And some of that is around their physical and their emotional well-being as a barrier to attending. So I'm wondering how then we start to explore that relationship between not attending at planned care and seeing that translate into unplanned and emergency care and use of other resources like primary care. Do you have any experience of that, either of you, in that context?
Yes, I mean, I do an integrated care clinic, so I go out to a GP clinic, a hub clinic, where actually there are several GP practices who refer children to that hub clinic, and we see patients who the GP feels does not necessarily need to be referred to secondary care, could still be managed in primary care, but needs a little bit more specialist advice. So, I mean, that's a great way, actually, of keeping patients out of secondary care. And it also aids in sort of educating GPs. So we do it as a teaching clinic, so that I have the GP in with me, as well as trainee doctors, so they see that sort of approach, and again, addressing the patient care more holistically. So that's one way, and then actually during those appointments we do a lot of education with parents around ED access, and what you should go to ED for. So hopefully that will prevent sort of back and forth visits.
And there's certainly data out there that suggests hotspots of patients who attend more frequently. And Aicha, I think you've done some work around high intensity and high frequency users.
That's right. So a few years ago, we did a piece of work around high intensity service users, where we worked as an MDT, like ED clinicians, as well as ambulance services and acute physician geriatricians. Actually, we worked together on this project. And what we identified, it was an acute secondary care trust in a very diverse population in East London. And we had over about 430 patients considered as high intensity service users. So these patients, when you call high intensity service users, any patient who attends accident emergency more than 10 times a year. And what we identified is these patients had over 1,200 admissions in that year. They had about 5,000 ambulance journeys, and their total cost for the local health economy was about 5.5 million a year. So you expanding in a system, in a reactive biomedical process, where you just quick fix problems, patient end up getting admitted, not getting much holistic care, being discharged back to the context and circumstances that made them sick in the first place, so the cause of their illness, and we keep just reactively quick fixing medical issues. And what we did during this project, we worked together with our colleagues within the integrated care systems, and we developed a role of care navigator and coordinators in accident emergency to early identify those patients. We use data to identify those at an early stage of their, when we see patterns of frequent accident emergency attendances. And that helped to proactively identify them. But also one of the cases, which I still remember, we had a 70-year-old who attended over 62 times A&E in a year, ended up being admitted 32 times. He had multiple comorbidities, including atrial fibrillation, heart failure, as well as a history of PEs, and he was on lots of medication that he was not taken. And on the top of that, he was a heavy smoker and he drinks alcohol excessively. So he, prior to all of these medical problems that happened, he used to be a university teacher, and he was high-profile professor, but he had an incident at university, and following that he got divorced and he lost contact with his family. So what we did he was our very first case study of high-intensity service users, and what we did, we developed an MDT where we had alcohol liaison service, as well as geriatricians, GP, and community nurses, all of us, and a geriatrician going all of us together to the patient home and hear the story. We knew about his actually social history during that visit. He didn't open up before. And during that consultations, he felt that he was empowered. We were all listening. We were just asking questions, being curious to learn more about him. And what matters to him most was to see his grandchildren. This is what made him depressed, is being away from his family, being lonely and ending up excessively drinking, being unwell, coming frequently to hospital. So as we can see, reactive system doesn't help the patient. Reactive system doesn't help the system. Reactive system is just wasting resources and on the top of that, unfortunately, driving poor patient's care. By addressing the wider determinant of health and holistic care, we can improve the best use of our limited resources and get a better care.
I mean, absolutely. And I think you've described really clearly that idea that the system is working for those who it was designed to work for. Yeah. And I think there is something to draw out in that around when we talk about patients who are accessing our services frequently, the conversation shouldn't be centred on them accessing the service frequently, but why is the service not working for those patients, and bringing those wider determinants into the conversation. And what would you say to those who would challenge back and say, that sounds like a really resource-intensive way to do healthcare? How would you start to articulate some of the reasoning?
So it's interesting because actually high-intensity service users are not high in number, but they are high in their use of the system. And the impact of poor reactive system is just poor quality of care for them. So their cost per capita is high. So if you make that best use of the cost per capita to address the cause of their illness, you proactively actually support them individually, provide more personalized care, address what matters to the patient, and equally you save resources over time. It's like I get the challenge as well when I was told, oh, health coaching, is not something that we can use practically. But you can have slightly longer conversations. You can spend half an hour than 15 or 20 minutes. But in the long run, you will have a shorter conversation because you set up a conversation around what matters to the patient, their goal. They will work toward that goal. They have their own options. They will try to test it. And when you see them again, it's a follow-up conversation. And you may reduce their need for further follow-ups over time. So you are investing in the long run. If we think about quick fixing, we think, what do I need to invest now? But this is not just a quick fix. It's a long-term journey that is focused and patient-centered.
And I don't know about you, but when we talk about something as being high frequency use or cost per capita, I start to feel a bit uncomfortable because that's not how we've been brought up in the NHS. We're here to do a service and deliver a service. But the reality of the situation that we're in is that inequalities are growing, that we know we are disadvantaging certain groups, and that is costing us a huge amount of resource and money. So we have to take some responsibility for that. And I'm just curious, Katie, as to how you would start to unpick some of that discomfort with colleagues who find those conversations just that bit too difficult to start to have.
Yeah, it's a real challenge. I think that, like Aicha said, sort of explaining putting the effort in now is going to make a difference in the long term. I think there's also there's a fear around exploring those other elements, because that then sort of suggests more work or the unknown. People worry that they don't know how to, they think they need to fix those problems. And as we know, many of them are not fixable, but it is possible to make, the patient feel listened to and to understand what they are finding so difficult, and what actually, as we say, matters to them. But there are also ways of sort of signposting these patients to other services. There are lots of things we don't know about that are out there. So it's a matter of sort of talking to the right people and putting together the right MDT. And I think there's so much more nowadays that we have access to online that we can, find out more about. So it's somehow getting rid of that fear that colleagues have, and the notion that this is really time consuming, whereas we say it's much more time consuming if we're seeing them again and again and again.
Absolutely. And then Aicha, thinking a little bit more about that idea of it being time consuming, and actually what we're discussing here is, yes, it's access to healthcare, but it's also about preventing unnecessary use of healthcare. Unnecessary meaning inefficient use of a system that is not working. So given that we all work in secondary care, one of the questions that I get asked a lot is what's the role of secondary care in prevention in the context of how people are accessing our services? Any thoughts on that?
That's really good question, and I think it does go back to what value we'd like to provide and how. So if we want to keep our patients well away from hospital, then we need to work as in an interdisciplinary way with other colleagues in the community. And our recent work and projects with young people in the community was quite insightful. So we did a workshop in a school where we met with 25 high school students. Most of them are interested in health and social care. And they essentially they learned about how the NHS function and explored career in the NHS, but also some of the idea that they came up with is, how about you do workshops on health promotions in our schools? Some of the students asked us, we do have already some workshops on sexual health. Why can't we have workshops on, staying well, or if people develop long-term conditions in your school, how can you support each others? How can we support people to stay well and remain well? And that's actually kept me reflecting on my role as a healthcare professional. So if I would like to go beyond quick fixing medical problems, perhaps working with colleagues in the community can help us to provide better care, more value-based care, which is investing more in health promotion rather than, addressing illnesses.
Yeah, absolutely. So I think I'm hearing a lot in there from both of you about taking services to the place where patients can access the service and listening to them about the barriers that they experience in engaging with us. So just to kind of round off the conversation, it would be just interesting to hear your thoughts on the co-production element of that. So we do a lot of information gathering, and certainly where I work, we have got a huge amount of information now around why people don't attend. What we're struggling with is, what do we do with that information, and how do we materially go back to patients and to communities and say, you've told us this is the problem, how can we start to fix that? So just your thoughts, Katie, first you around the co-production and how we make that work for acute and secondary care.
We really need to be listening to our teenagers, absolutely. And I think, it sounds like you've collected a lot of data in Leicester. I think we need to be really making sure we're all collecting that data, and particularly on the less engaged populations. And I think we need to hear much more from teenagers about what they want. I'm here saying we should be going into schools. I'm not certain that that's what they want. It sounds like a good way of managing it, but really working with them and seeing if that is really what they want.
Absolutely. Any thoughts, Aicha?
Yeah, I think to me, one of my dreams is to normalize partnership with our patients and make it part of the normal, that anyone who uses our service is part to improve the service. And the same within our communities as well. If we could engage more with our communities, we may have lots of answers. We don't have to outsource or find someone to think about solutions for us. We can address those issues. And definitely the recent work we've done with young people has been amazing, because these are young people who are using our service and now they are part of our improvement journey. So our recent engagement events, which we planned for like after 5 or 6 organizing committee meeting, fantastic presence, and most of young people contribute to the planning. And then we had a young person who co-facilitated the day. We did simulation trainings where healthcare professionals were taking the role of patients and the patients were playing the role of healthcare professionals, and we learned a lot from that exercise. Imagine if every single departments, they work that closely with patients. First, we manage expectations. Everybody know that the system is not perfect, but everyone know that they have a role to improve the system.
Perfect. So I think, just to conclude and sum it up, Katie, I think what you said around reflecting back to patients, we think this is the solution. Do you agree? Have we heard you right? And then involving them in the response to that problem of developing the solution. And that's small steps towards improving access, but necessary steps towards access. Yeah. Thank you very much. It's been a pleasure as always. And thank you for listening.